Welcome to the Analyzing MSPB Data to Identify Primary Drivers conference call. My name is Allie, and I will be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. During the question-and-answer session, if you have a question, please press star then 1 on your touch-tone phone. I will now turn the call over to Sarah Brinkman. Sarah, you may begin.
Thanks, Allie. Hello, everyone, and welcome to our webinar, Analyzing MSPB Data to Identify Primary Drivers. This is the second in our series of 3 focused on Medicare spending per beneficiary, and we're so glad that you joined us today. Before we jump in, let's address a few housekeeping items. Those of you who registered before today should have received a reminder, actually 2 reminders this morning, including a link to the webinar event page where you can find the handouts for today's presentation, and our colleague Ross will be posting that in the chat box as well. A recording of today's webinar will be made available in a couple of weeks, and you'll be able to find a direct link to that recording from the same event page. We encourage you to ask questions throughout the presentation utilizing the chat function, and we will address your questions at the end and open up the lines for folks to question or comment over the phone as well. We'll also be asking you to participate in a poll midway through today's presentation and appreciate your participation in that. Finally, when you close out of today's webinar, you'll be automatically redirected to a short evaluation. And we greatly appreciate you taking a few minutes to provide us with feedback, which we'll use to inform the remainder of this webinar series as well as future educational offerings. Upon completing the evaluation, you will receive a certificate of attendance for your records. As was mentioned, this is the second in a 3-part webinar series focused on Medicare spending per beneficiary. During the first webinar, we laid the groundwork for understanding the measure. Today, we'll dig into some of the regional data analysis to identify some of the most frequent drivers of the MSPB measure in order to better understand what hospitals and healthcare systems can focus on in terms of improving performance. And finally, on September 20th, we'll discuss quality improvement strategies to impact these primary drivers, considering the roles of various settings of care. So we'll jump in for today's presentation. I'll introduce myself. My name is Sarah Brinkman. I'm a program manager with Stratus Health, which is part of the Lake Superior Quality Innovation Network. I'm located in Minnesota, and our partners in the Lake Superior Quinn are in Wisconsin and Michigan. And later on, you'll be hearing from Eric Zabel, my colleague who also works here at Stratus Health. Our objectives for today are to understand the basics of the hospital-specific MSPB data files and reports, to review the factors that influence MSPB in the context of the MSPB timeline, and to learn about regional and state trends and primary drivers of the measure. First, we'll have a little refresher from our first webinar, and we will post a link to where you can find a recording to that webinar in the chat box as well, as if you weren't able to join us or if you'd like to review that after the fact. So what is MSPB? The Medicare spending per beneficiary measure allows us to evaluate hospital efficiency relative to other hospitals as it relates to spending on Medicare fee-for-service patients. For MSPB, lower scores are better, indicating greater efficiency, and this measure is currently the sole measure making up the efficiency and cost reduction domain of the hospital value-based purchasing program, thereby impacting Medicare fee-for-service payments to hospitals participating in VBP. I'm going to take just a couple of minutes to ground ourselves in the MSPB measure methodology by reviewing the timeline that was presented on the first webinar. When we talk about an MSPB episode, it begins with an admission of a Medicare fee-for-service beneficiary to an acute care hospital. And the time from admission to discharge is referred to as the index admission. The MSPB episode begins with any Medicare fee-for-service claims made during the 3 days prior to the index admission and extends to any claims that start within the 30 days following discharge. An important distinction here is a claim may start anytime during that 30 days and extend beyond the time frame. So, for example, if a patient is admitted to a skilled nursing facility 29 days post-discharge, the entire Medicare fee-for-service claim for that day would be counted toward the episode spending for Medicare spending per beneficiary, even though service dates are beyond the 30 days post-discharge. So what you see here on this current slide is the actual spending that's measured for MSPB. But there are a number of factors to consider in terms of risk adjustment for the final measure, including any hierarchical condition categories, or HCCs, that are coded in the 90 days leading up to the beginning of the episode. In other words, 93 days prior to the index admission. So HCCs and other risk factors such as age, ESRD or disability status, and so on may drive the expected spending for a particular beneficiary higher, and therefore provide the hospital a bit more wiggle room, if you will, as it relates to the final calculation of the measure. If you'd like more detailed information about how MSPB is calculated, we encourage you to check out webinar 1 from this series where we focused on that solely. But today we're going to move on and use this timeline as just a baseline of our understanding for being able to look into the data analysis. So during today's webinar, Eric is going to walk us through the data available to us via the hospital-specific reports for MSPB, and then share some of the ways we've looked at the data at a regional level and that you may want to consider at a hospital or health system level to help inform your quality improvement interventions. Throughout, we'll come back to this timeline to help us understand what period of time we're focusing on with regards to the episode. One last thing before I turn things over to Eric, it can always be confusing when we're talking about quality data to orient ourselves to the time period being discussed. For all but a couple of today's slides in today's presentation, we are focusing on data reflecting performance in calendar year 2016, provided in the 2017 hospital-specific reports for MSPB that came out this past spring, which will impact payment in fiscal year 2018. And with that, I'll turn things over to Eric.
Okay, well, thank you, Sarah. So, as Sarah said, my name is Eric Zabel, and I'm an epidemiologist here at Stratus Health, and I've been working a lot lately to try to help figure out what the MSPB measure is all about, and looking at some of these sources of data that we have. And right before I started, I just wanted to mention that as you hear me talk, I do sometimes stutter when I talk, so that if you hear pauses, that probably is what is happening, just so you don't necessarily think there's something wrong with the phone. So let's get started to go through the data. So what I'll be doing the first part of this talk is kind of going through the sources of data, and then the second half will be looking at some very preliminary data and analysis that we have done just to kind of scratch the surface of what we can find. So there's two major pieces of data, as I think of it, that are available. First is the publicly available data that's found on hospital compare, and what is currently on there was last updated in December of 2016, and this is for payments, or excuse me, this is for services that happened in calendar year 2015 that will have an impact on the fiscal year 2017 payment. And there's a lot of different pieces of data that are on there, and you can see that for any hospital across the country. The second big chunk of data that is out there, you all should have received from CMS in May of 2017. And these sets of data are all actually for the services that happened in calendar year 2016. So these are, first off, the hospital-specific summary report, and this is a PDF-based report that has a lot of text describing the MSPB measure, but it also has a few tables that provide some data on your specific hospital as it compares to your state and the nation. The three other files that I have up here are the beneficiary episode file, the beneficiary risk score file, and the index file. And these are three Excel-based files that are provided to you at the same time as the hospital-specific report. And these all contain line item data on your individual episodes. So these first few slides I'm going to talk about are really looking briefly at the data tables that are available in that PDF-based hospital-specific report. So the first is quite a simple table, just listing what your hospital's MSPB measure was. Second would be an expansion of that, looking at simply the number of eligible admissions there were at your hospital, your hospital's MSPB amount, which is the number that is used to calculate the measure, then the state's average MSPB amount, and then national. The third table is a little bit more of an expansion, and as you can see, this will contain the number of eligible admissions. Then we have the average spending per episode, so this would be your actual spending. Then the MSPB amount, which is a combination of your actual spending with the expected spending, and then under that we have the national median MSPB amount, and then finally the actual MSPB measure. And I should say that for these to show these examples on this webinar, we did choose to not show any specific hospital data, but we are showing what the state and the U.S. data, and this data for the state was from Minnesota. And CMS in these reports also does provide you a couple of ways to see the national distribution of the MSPB measure to see where your hospital falls. And so we can see from this distribution here that quite a high percentage of the hospitals tend to fall in the 0.8 to 1.2 range for their MSPB measure, and about half the hospitals had a measure between 0.95 to 1.05. So you can see there isn't a terrible great spread here. Table 4 in that report then just provides a little different way for you to compare your MSPB value with the different national percentiles. And now we'll get into some more complex tables. So Table 5 in the hospital-specific report does contain quite a bit of data. So you can see on the left-hand side we have those 3 time periods. So there's the 3 days prior to admission, the during the index admission, and then the 30 days after the hospital. And so for each of those 3 time periods, we have the claim spending broken down for those 7 different types. So we have the home health claims, hospice, inpatient, outpatient, skilled nursing, the durable medical equipment, and the carrier file, which is basically the physician or other provider costs that are billed separately. And so For your actual hospital data, they will provide the dollar amount of spending per episode broken down by all these different types and the percent of your episode spending that is falling into each of these. They also provide the state and national data, but for those, they only provide the percent. So, Table 6, then, the final piece of data in that report is another detailed breakdown of MSPB spending. And for this one, they break it down by the major diagnostic categories. And we have just chosen to show the first three here. Otherwise, it would be quite a long table. So there's 25 of the MDCs that will show up here. So for these, for the hospital, the state, and the nation, then for each MDC, they will show what the average spending is per episode and the average expected spending. So this could be a good summary to look at to see for which diagnostic groups is your hospital maybe doing worse or better than the state or the national average. So that is what is found in that hospital summary report. The next files that I'll be talking about are these Excel-based line item files. And these, I'm not sure how many of you at the hospitals have looked at these or worked with them, but that's something that you'll be interested to hear about. So I'll start with the beneficiary episode file. So this contains a list of the episodes that are counting for your hospital for the calendar year of 2016. And there'll be one row of data per episode. And some of the items that this set of data has. First off, I should say it includes the Medicare beneficiaries HIC number, which may be very helpful if you wanted to link this file up with your data from your own EHR. Secondly, it also includes a number assigned to each episode. So that is the number. Between that number and the HIC number is what lets you be able to link these files. This episode file also contains the ICD-9 or ICD-10, the diagnosis of that index hospital admission. It includes the major diagnostic category. It includes that episode start and end date, and then the payment amount for that episode, broken down by the total payment, the standardized payment, the predicted payment. And then after these factors, there's a whole set of columns that this set of data has that breaks these payment amounts and start and end dates down by the different claim types. So this is where it's broken down by those 7 different types. And they also include in here some data on the top 5 providers that had claims for this episode. The second of these Excel files is the beneficiary risk score file. So this one, in a similar manner, has a list of episodes with one row of data per episode. And what we have in here, besides the beneficiary SIC number and the episode number, we also have the DRG that's assigned to the index admission. We also have the payment amounts. We have the major diagnostic category of the index admission. And then we have the risk equation data. Now these are the some of the data points that Sarah had mentioned before that will go into your risk adjustment that it is used to calculate the predicted payment. So you can see what is in there is the DRG, those hierarchical condition categories from the claims 90 days prior to the episode. There's age, disability, end-stage renal, and the long-term care indicator. They also include several interaction terms that go into the risk equation. The third of the Excel files is the index admission file. And this one is a little bit different in that there can be more than one row for each episode, because what they have in each row is a hospital admission stay. So it's not just the index admission, but it also includes any re-admissions. And so as you can see where I have listed out the different items, this second item on here is a flag that just indicates which of these are the index hospital admission. This also has details on why each of these admissions are included or not included. It has the diagnosis codes that were assigned for each of those admissions, the MBC, and then the payment amounts.
Okay, so we just real briefly wanted to get a sense from all of you, so if the folks from Ventec could queue up our polling question. We would like your feedback and to understand, now that Eric's reviewed what you all received from CMS in the form of a hospital-specific report for MSPB, how is your hospital using the information from, and this says the MSPB data files Excel. We'd also be interested to know how you're using it for, in terms of the PDF files. So your answer choices are A, I've never heard of this before now. B, our team has reviewed it, but we didn't know how to make use of the data. Or C, our team actively analyzes the data provided. And so the polling question is live right now. If you want to go ahead and select your answer. If you do select C, we would really appreciate if you could share with us in chat some of the ways that you have used the data. We're going to review some of the things that we've done in terms of regional analysis with the data. And at the end of the webinar, we'll make some suggestions of how you might want to think about additional data analysis beyond what we're going to provide here. But we'd be really interested to hear from you. I think the poll is closed, so we should have our answers here in just a moment. All right, so a majority of people said that you've reviewed it, but you didn't really know how to make use of the data. So hopefully that quick review of what's included and some of the suggestions Eric made about being able to link the data together or to use certain identifiers to link it to potentially your EHR data will be useful. And then as we walk through the remainder of today's webinar and then some suggestions at the end, we'd be interested to hear from you if you have any questions about what that data analysis might look like. A couple of you did answer C, that you're actively analyzing the data, and I hope that we'll see some further explanation from you in chat as to how you're doing that.
Okay, then with that, that's a good spot. That was a nice break, because now we're going to go into talking about some of the actual data and analysis that we have done with these files. So we're going to talk very briefly about data that we used out of the hospital compare, and then some from both the PDF hospital-specific reports and the Excel files. So what I'm showing here is the data that we pulled out of hospital compare, and because this is public, we are then able to get data basically on all the states across the country. And so I have them on here from lowest MSPB score up to the highest. I have the national average of the MSPB scores in that red line, so that's a 0.99. And then I have in green here the 3 states within our region. So we have Minnesota on the far left in green, then Wisconsin is in the middle one, and then Michigan. So you can see that Minnesota has the lowest MSPB score for our 3 states. Michigan at the highest, but still all are below the national. So now we took some of the data from those hospital-specific reports and entered them into our own spreadsheet, so we could just look at a summary of the data from that table 3, just looking at our 3 different states as compared to the national. So we have the total spending per episode, the MSPB amount, the national median amount, then the MSPB measure, and just for information, the number of eligible hospital admissions. So here we see that Minnesota actually has the highest total spending per episode of our 3 states, even though Minnesota has the lowest of the actual MSPB scores. So this would indicate that Minnesota must have a higher value assigned to the expected spending. So that's a very interesting factor we'll kind of look at a little bit further on. Now we have just a short comparison of the state's MSPB performance, comparing the data from the 2015 calendar year to the 2016. And we see that each state, Minnesota and Wisconsin, both got a little worse MSPB score in 2016 than they had in 2015, whereas Michigan's score did drop. But as we said, they're still all 3 better than the national average. So now we're going to go back to our timeline for just a second. The next couple of slides that I'll be showing are really emphasizing the spending that happened during the episode. So it's that whole range of 3 days prior to the index admission to 30 days post. So we took, as I said, we took the data from those hospital-specific reports and kind of tallied those up for each state. So we have the total pre-index on the far left, then the during index in the middle, then the post-index spending on the far right. So we have that for our 3 different states plus the national, and this is simply the percentage of the episodes that fell into each of these times. So you can see that the pre-index costs are really only adding a small percentage of the MSPB spending. As you might expect, that during the index stay costs are the largest. The post-index are somewhat less, but still, as you can see, contribute a high percentage. And what we saw here is that if you look in the light blue, Michigan had the lower percentage of spending during the index definition, but a higher amount in the post-index time, where Minnesota in the dark blue had a substantially higher amount of spending during the index, but a smaller amount in post-index, and Wisconsin sort of fell halfway in between. And this just breaks this spending out by these claim types further. You can see, once again, we have the pre-index, during index, and post-index time periods, but we have it broken out by the 7 claim types here. And what we found kind of interesting, as we said before, is that Minnesota has the higher spending during the index time, and then lower spending during the post-index. And as you can see, that kind of went across all these different claim types, especially the home health, inpatient, and skilled nursing. And here we have this similar graph, very, very close. This is the same graph, but with the actual dollar amount put in. It really doesn't tell us a lot different, simply because our total spending per episode for our 3 states truly aren't that different. Now we're going to move to some data that focuses on the actual index admission time frame. And what we looked at here is looking at the diagnostic weighted group that was assigned to that index hospital admission. What we have here is the most frequently seen ERGs for our region here. And you can see the regional count is in the 3rd column, and the percent of all the episodes that were accounted for by that ERG is in the 4th column. And then in the last set of columns, we have the ranking by each state of where that ERG fell. And so you can see by far we have the major joint placements are seen as the most common DRGs, and that was held true across all 3 of our states. The second was sepsis, and you can see that there's actually 2 different codes for sepsis in this second row and the 6th row. And so we see that sepsis was the second. The third tended to be heart failure, but after those top 3, we tend to get a little bit of difference that happens between the states. And we look a little further at that in this next slide. This is just looking at some specific examples of where we saw some of these DRGs showing up in this top 10 list for 1 state maybe, or 2 states, but not all. Most of these still fell in that 8, 9 to 10 ranking, but we did see one very interesting thing is that if you look in the second row down, that for Minnesota, we actually saw that the DRG group of psychoses actually ended up third most frequent. And we're not really sure yet why that is. So now I wanted to look at the DRGs as far as their cost. So this is basically adding up all the episodes with each of these DRGs and seeing what the total spending was for our entire region. And you can see that the dollar amounts really kind of add up. So we have the total cost and then the count of the episodes and then the median per episode cost of those DRGs. And you can see that this tends to follow the same ranking as those when we rank the DRGs by their frequency, which would make sense that the DRGs we see that the most frequently would contribute the highest to the cost. Although if you look down to the third and fourth and fifth row, you can see that there are a few DRGs that weren't necessarily in the top 10 as far as the frequency, but because their median per episode cost was higher, it really contributed substantially to the spending. And most specifically I see on here is the infectious and parasitic, which tends to have all those hospital-acquired infections, which seems to be something that could be used for quality improvement. And finally, as far as these DRGs, we just looked at those DRG codes that are the most expensive on a per episode basis. And as you might expect, these are some of the real substantial groups here. Like quite a few of them are for transplants, or for instance, for being on ventilator for a substantial period of time. So the next time period that we'll focus on is going kind of back in time to that 90 days prior to the start of the episode. And this is where all of the risk factors come in. And for the purposes of our talk today, we really just focused on these 70 indicators for the hierarchical condition categories. And you can see, as we mentioned, that these are derived from the claims that happened 90 days prior, and they do include some interaction terms. So we went through and summarized what the dollar amount assigned to each of these HCCs was, and summarize that up by HCC for the hospital episode. And so here we have the ranking of the HCCs that contributed the greatest dollar amount to the hospital's expected spending. And as you may expect, some of these high ones are AMI on pneumonia. We saw several that relate to paralysis, which seems somewhat strange that they'd have such a high number of episodes. But I think this really has to do with the fact that these HCCs are comprised of a whole set of ICD-10 codes, and I from what I looked at these, they, each of them can comprise a range of severity. So the titles of these HCCs aren't necessarily as important as looking at what those different codes are that go in to them. So the most frequent HCCs are shown here, and we saw that heart arrhythmias had the highest number of episodes with any dollar amount assigned. And you can see that these more frequent HCCs tend to be not as expensive, or they didn't contribute as much to the total expected spending. But since they are found in such a high number of episodes, they may be very important for adding to each hospital's expected spending. And for our final set of the data that we looked at, we focused on those costs that are happening in the during index to 30 days post index, which, as we saw, the bulk of the costs for each episode are found here. So we have this table here that looks at MSPB spending by the claim type, and some of this we showed in a different form before. I think it's helpful to also look at it at this table and putting the multiple kind of pieces all in the same spot. So we're seeing the total cost here at the top for pre, during index, and post index for each of our 3 states that end in nation. And then for the post index spending, we have those broken down by the 7 types. And this just kind of emphasizes that same data we looked at before, where Minnesota, if you look at that in the center, you can see that we had about 60.4% of the spending in the during index time and 35% in the post index, which was a fair bit different from Michigan, that you see on the left. And then if you look in the post-index breakdown, you can see that that was a pretty consistent difference among these different types, especially the home health, the skilled nursing, and the inpatient spending. We actually saw that Minnesota, in contrast, had a little higher spending in the post-index outpatient. And what we also saw, if you look further down this table, is that the length of stay for that index hospital admission was the longest for Minnesota, shortest for Wisconsin, and in between for Michigan. And this is important to me because we see that Minnesota then subsequently has the highest total spending per episode, but as we saw before, Minnesota has the lowest MSPB measure. So there's a few things that may be happening here. One is that Minnesota may have more risky patients that are being seen at the hospital, which would then drive up their expected spending, and it would assumably also lead to a higher amount of spending during the index admission and cause a longer length of stay. But then it's interesting to see that Minnesota then had the lower MSPB measure, which could be some indication that maybe a longer hospital stay and more spending during index may help lead to lower overall spending. But those are just pure ideas that we had from seeing this. Data. And before I end myself, I just wanted to say that what we've done here is really just scratch the surface. There's so much data here. There's really a lot to explore.
Great. Thanks, Eric. As Eric said, there is a lot that you could dig into, and since we were looking at a regional level, we were trying to keep our analysis to things that we thought would be kind of give us some indication as a team in terms of things we might want to focus on for educational efforts or for our third webinar in this series. But some other possibilities for those of you who are interested in able to dig into this data further at a hospital or health system, some things we thought might be interesting if we had had the time and the resources to do that would be to look further into those hierarchical condition categories to understand what's being documented, and then also potentially what's not being documented. So obviously if an HDC isn't there, that doesn't mean that there was a lack of documentation. Maybe there wasn't an HDC to capture. But based on your knowledge and understanding of your patient population, and then maybe doing that link into your electronic health record, understanding how that documentation is happening. And that will not only potentially increase your expected spending and thereby decrease your potential, hopefully drive down your MSPB score, but also identify some opportunities for being able to work with patients in the outpatient setting as opposed to having them be admitted or readmitted. We also thought it would be really interesting to look at what your readmissions or your post-acute care costs were versus your index costs. As Eric pointed out, we had kind of that anomaly. Michigan was very much in line with the nation for their spending inpatient and for their post-acute or for their post-index costs as well. Wisconsin was somewhere in the middle, and Minnesota was completely opposite, where we had the higher inpatient expenses during the index stay, and then the post-index were lower. So it'd be interesting to look at what are your readmission costs versus your index costs, or your post-acute care costs versus your index costs. We looked at what the top 10 most costly DRGs were for the region, but it might be interesting for you as a hospital or health system to look at what your most costly DRGs are and analyze those in terms of what are the contributing factors for pre, during, and post-index. Digging into those DRGs further to really understand the ICD-10 codes that contribute to them and what your most common ICD-10 codes are. And then, as we said, linking that data to the EHR to assess your severity and to help understand if the documentation is an issue or if things kind of line up with what you're expecting to see based on your data collection. For us, we walked away with really with kind of some more questions than we maybe have answers, but we were interested in looking at the impact of care on the sort of post-index discharge and digging in a bit further into the different carrier types. So the different claim types. When you looked at the claim types for pre-index and index costs, they really were just about the carrier and the outpatient setting for the pre-index cost and the carrier and the inpatient setting for the index cost. But post-index, it's the whole slew of all of the different claim types and understanding what all of that play there. We wanted to have, look at what balancing those costs are for index with the cost for post-index care. So it's a longer length of stay of value when the hospital has more control over what's happening in terms of patient care delivery than potentially having someone discharged maybe too soon and then having to receive additional care in a post-acute care setting. Looking at ambulatory care documentation, as we talked about with those hierarchical condition categories. And there's so much more analysis to be done. We know that we're just scratching the surface, but we really have enjoyed digging into these data files and trying to figure out how to make use of this very complicated set of data that CMS is providing. So with that, I'd like to open the phone lines up for questions or comments. We did have a couple of folks who indicated in the poll that they are using the data and doing some analysis. We really would love to hear from you. What kind of analysis are you doing? Does it look similar to what we looked at? Is it something completely different? How are you sharing that data or making sense of that data so that others who aren't as familiar with this measure, since it is so complex, have the ability to look at what you're analyzing and make sense of it, and how are you using it to inform your improvement activities. So, Allie, if you could provide instructions for how folks can get on the line.
Absolutely. We will now begin the question and answer session. If you have a question, please press star then 1 on your touch-tone phone. If you're using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, that is star then 1 on your touch-tone phone. And we are standing by for questions.
Great, thank you. Ross, I'm not seeing any questions that have come in chat.
You are correct, Sarah. We have not received any questions in chat.
Okay, great. We really want you to not be shy. We would really appreciate hearing from you and learning from your questions or your comments with regards to this analysis that was offered today.
And as a reminder, that is star then 1 on your touch-tone phone for a question or comment. And we have no questions or comments at this time on the phone.
Thanks, Allie. Well, we're going to stay on the line for a couple minutes in hopes that some brave souls will share with us, because we would like to hear from you. It really does help us to better understand the issues and identify ways that we can better support you the more we hear from you. But as a reminder to those of you who are going to be hopping off of the call, as we close out of the WebEx today, you will be automatically redirected to an evaluation. And we really ask that you take a couple of minutes to provide us some feedback. It's a very brief evaluation. Let us know how we did today, things that you're interested in learning more about. We do look at those and take those into consideration as we're making our planning for future events. And upon completion of that evaluation, you will receive a certificate of attendance or participation for today's webinar for your records. But Eric and I are going to stick around for a few minutes in hopes that someone would like to chat with us. We'd love to hear from you. So again, that's star 1 on your phone. Okay, well, hearing none, well, thank you all for participating today. Please do take a few minutes to complete that evaluation. If you have any questions, Eric and my contact information is provided on this slide. Links to the slides were provided in the chat box as well as sent out via your registration reminder. So we hope to see you all on the call on September 20th, and I look forward to hearing from you in the meantime. Thank you all.
Thank you, ladies and gentlemen. This concludes today's call. Thank you for participating. You may now disconnect.